Hello, my name is Brian Higgins. I'm a registered nurse with the Minneapolis VA, and in this presentation, I will be discussing a change project to bring care coordination to the Minneapolis VA healthcare system. Through a systematic review and a process improvement system, this change will assist the Minneapolis VA with achieving triple aim for its veterans. What is care coordination? Well, the goal of the Institute for Healthcare Improvement developed triple aim for its improved healthcare. Key, care coordination is key to that success. Doggone it. My name is Brian Higgins, a registered nurse with the Minneapolis VA. In this presentation, I'll be discussing a change project to bring care coordination to the Minneapolis VA healthcare system. Through a systematic review and process improvement system, this change will assist the Minneapolis VA with achieving triple aim for its veterans. What is care coordination? Well, the goal of the Institute for Healthcare Improvement developed the triple aim for improved healthcare. Care coordination is key to the success of any organization to meet the goals of triple aim. Those goals are to improve overall health care of the community, reduce the overall cost of health care, and improve patient satisfaction. Care coordination can improve the community's health by improving patients' access to health care. By coordinating efforts of the organization, a care coordinator can help a patient overcome barriers to care, such as costs, travel, education, and cultural differences. According to Lamb, it is more cost effective for a patient to be treated in the community they live in rather than in a hospital setting. In a hospital setting, there's an increased risk for falls, injuries, and hospital-acquired diseases which can either be eliminated or minimized in the home care setting. While care coordination can help any system meet triple aim, care coordination affects an organization's bottom line. A decrease in healthcare costs can not only help the bottom line of the Minneapolis VA, but also improve access. With veterans living across two different states and up to hours away, effective care coordination can reduce costs related to veterans' health care, including travel costs to and from the Minneapolis VA. With less money being spent on transportation and healthcare costs related to treatable and preventable diseases and illnesses in the community, the Minneapolis VA can then divert those funds to other services and improve the facility. The use of care coordination can also be used to preventatively treat diseases and illnesses before an admission, and also be used to alter the plan of care. Hanan discussed how early identification of poor responses to treatment plans can be used to change those treatment plans for the patient. He discussed how even early poor response to treatment plans can indicate failure for that plan of care. With care coordinators being involved in the treatment goal of the veteran population, failure, even in early poor responses, can be identified while in the community, and plans can be adjusted or changed to improve patient care. If we use the example of congestive heart failure and care coordination, we can see how this would work. With a patient re-diagnosed and being treated, a care coordinator can place a phone call to discuss how the plan of care is working. Weight gain can be discussed, as well as sleeping patterns, much of which may not be discussed prior to the patient's next planned appointment. By identifying these needs and trends early in the treatment program, medication changes can be made, care plans amended, and potential admissions can be avoided. In short, when we discuss stakeholders, the stakeholders are everyone. However, to narrow the conversation down a little, we'll focus on three major groups affected by care coordination within the Minneapolis VA system. Those groups are internal providers, external providers, and the patients. All care starts with the internal providers. That is the primary care providers and specialty care providers within the VA system. Most care is provided by these providers, and many veterans prefer to get their care through the VA system and with our providers. However, we cannot offer every service for our veterans. Occasionally, we have to refer a veteran out for care. This could be due to the fact that we either don't offer the service, the wait for the service is too long, or the veteran simply cannot make it to the VA. This transfer of care can leave either provider wondering what is going on with their patients. Community providers and internal providers operate within their individual silos, and there isn't a system to allow for easy communication between the two sets of providers. This gap in communication can be bridged through care coordination. With nurses leading the way, medical records and information can be more easily shared between stakeholders, with all parties getting the latest information. Medication changes can be communicated between all specialties. Imaging, labs, and other data can also be shared. This sharing of information reduces the duplication and effort, helping to reduce the costs in veterans' health care. Often, treatment is provided, and because of these silos, the veteran's primary care provider may not know until the next clinic visit. Primary care providers are sending veterans out for care and often don't know what care is being provided. A patient could be referred to an orthopedic surgeon and then visit his primary care doctor a year later on an annual follow-up with a new knee. With care coordination, we'll be able to ensure a closed loop in the treatment of the patient from ordering provider to specialty care, then back to that ordering provider. Without care coordinators, this closed loop treatment seldom happens. With all of this coordination flowing behind the scenes, the veterans can show up to appointments knowing that all appropriate documentation and authorizations for care have been sent ahead of time. No longer will they need to go back and forth between the silos, hand-carrying information, or trying to recall what that yellow oblong pill is for. This creates a smoother transition from one provider to another and improves the veteran's satisfaction with his care. There are various resources that will be needed to ensure the Minneapolis VA will be able to provide adequate care coordination. The first is staffing. Currently, there are 6 nurses, 3 LPNs, and 1 assistant nurse manager within the department. To be able to handle the amount of veterans within our network, there will need to be an additional 6 nurses, another 3 LPNs, and another assistant nurse manager. Those additional nursing staff, training will need to be conducted, and the plan for training can be discussed later. With extra staff comes the need for extra hardware to do the job. With a computerized charting system, electronic faxes, and other informatics, the additional nursing staff will need to have the proper hardware to complete their job. This includes computers and monitors with a dedicated phone line for each nurse. There are already copiers and other peripheral devices within the department, so those items will not be needed. Lastly, with extra staff comes extra room. There are currently plans underway to rearrange the workspace in our current location to allow for the addition of this extra staff. With regards to this change, we're looking at it through Lewin's theory of planned change. With this plan being presented, the stage of unfreezing has begun. We've identified the need for care coordination and planning for this change. The workflow and plan of action is being developed to ensure the transition can not only take place, but make it as smooth and seamless as possible. In the moving phase, this is where the hard work begins. With all of the work being remodeled to accommodate the additional staff, hiring and training are key. With 9 total new nursing staff being hired, the plan for hiring will be staged. To prevent the current staff from being overwhelmed with training of the new staff, we're planning to hire a combination of internal or lateral transfers and new hires. The internal transfers will be brought into place first and quickly trained into their new roles. Meanwhile, outside hires will be staggered in their start dates approximately 1 month apart. New hires will need to go through new employee orientation before getting their on-the-job training in the care coordination roles. This will ensure that each new employee will receive the training and attention they need to be successful in their new roles. Care will also need to be taken for hiring a new assistant nurse manager. When hiring for this new role, it will be important to hire an impassioned champion that can provide inspiration, visions, and support to all stakeholders and staff members involved in this change process, including after this change has occurred. Another quality that will be needed in the assistant nurse manager will be emotional intelligence, which is key to being an effective transformational leader. According to Kim, a leader that has emotional intelligence has the ability to perceive, understand, and manage the emotions of both the self and others to accomplish personal and collective goals. The final stage of Lewin's theory is refreezing. In this stage, the new normal has developed, and the change that has been worked toward is now the process. Each staff member has become accustomed to their new role, and the stakeholders have also adapted to this new process. New policies and procedures are written to ensure staff are held to a set standard of care and procedures for conducting their daily activities. Quality improvement will follow the Plan, Do, Study, Act model. This current process is currently in the planning stage. We have examined our current approach and developing a plan to change for the future. We are hiring staff to assemble our team, and we are hoping to progress towards implementing that plan of care coordination in the near future. We will then study our actions and make adjustments as needed and fine-tune our process. We will act on our newly established standards and then examine ways to make the process better, starting the planning phase over again. We want to continue to develop our process as new evidence-based practices are released so that we can continue to improve the health of our veterans, reduce healthcare costs, and improve patient satisfaction. How do we measure success? Well, first we'll need to be able to measure in our success. If we continue to use triple aim as our goal, we have established benchmarks based on past performance. First goal is to reduce the overall healthcare costs. We know what our healthcare costs are in the past years and can trend that information. Once care coordinators in place, we'll be able to trend the expenditures of those costs in the future and examine the cost savings that care coordination can bring. The second goal is improving the health of our veterans. Again, there are already quality measures in place. Congestive heart failure, diabetes, warfarin use in education, and hospital readmission rates are all currently being recorded, and the use of care coordination can be compared to past performance measures. Lastly will be satisfaction scores. While this isn't one of the new measurements, we can send surveys to patients and outside providers to assist in measuring how we are performing. We would expect initial low scores as vendors and veterans adjust to the new system. However, once the benefits are realized and the veterans feel less alone in their health care plans and needs, we would expect these scores to improve. To assist the Minneapolis VA with improving the quality of health care, care coordinators are needed. Care coordinators will assist with bridging those gaps in various healthcare silos, both inside and outside the VA system. Care coordination will also help the Minneapolis VA achieve triple aim by improving the health of our veterans, decreasing healthcare costs, and improving the veterans' satisfaction in their healthcare benefits. Care coordinators will be benefiting all veterans. To ensure smooth change in process, we are using Lewin's theory of plan change as well as the Plan, Do, Study, Act model for quality improvement. We can ensure the process is well thought out and executed. As we move forward with this change initiative, we must remember the words spoken by President Lincoln, which are echoed in the motto of the VA. We are here to care for him who shall have borne the battle, and for his widow and his orphan. Care coordination within the Minneapolis VA will help ensure we keep that promise to our nation's heroes.